Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I am pleased to welcome you all to our second live educational event for the day titled Infections, Vaccines, and Immune Health During Treatment. This is a topic that we get many questions about, especially as we shift into the colder season. Some might call it flu season. So as mentioned previously, this Zoom software does not allow you to access video features or turn on your microphone. At the end of the presentation, we will try to leave a few minutes for questions, and in order to do so, you can type them in the questions box, which is in the middle of the black toolbar at the bottom of the screen. Given how many questions we got in the last session, I'm sure everybody's able to find the chat box, which is great. So without taking up any more time, I would like to introduce our speaker joining us today. We have Dr. Abhi Vijenthra, who is a hematologist and clinician investigator at Princess Margaret Cancer Centre in Toronto and assistant professor in the Department of Medicine at the University of Toronto. She completed her medicine training in Ottawa and internal medicine, hematology, and lymphoma subspecialty training in Toronto as well, followed by a research fellowship in chronic lymphocytic leukemia at the Dana-Farber Cancer Institute, and she has a Master of Science in Clinical Epidemiology at Harvard University. Dr. Vijenthra's research focuses on outcome research in patients with lymphoma, with a particular interest in CLL. So thank you, Dr. Vijenthra, for joining us today, and you can get started as soon as you're ready.
Thank you so much. Nice to meet everyone virtually. So I'm Abby, and I wanted to thank the organizers for giving me the opportunity to give this unique topic as a talk, infections, vaccines, and immune health during treatment. So I don't have any financial disclosures, but I did want to sort of say that I'm not an immunology expert or infectious diseases expert. So I'll be sort of speaking from my perspective as a hematologist in this talk. As you saw in the session overview, we're going to explore how lymphoma and CLL, along with their treatments, can affect the immune system, learn about the risk of infections, the role of vaccines, and steps you could take to protect your health during treatment. And hopefully the session will provide some practical information to help you feel more prepared. So I think, why are infections important? Why are we doing this talk? No one likes dealing with infections, but we also want to think about how long people are living with lymphoma. And whenever we treat lymphoma, our goal is to improve quality of life. And the last thing one would want to do is shorten life by side effects of treatment. But unfortunately, infections do end up being an important predictor of survival in people with lymphoma. So it is something important to keep in mind. When we look at studies of people who have had treatment for lymphoma, we know that infections are a common cause of hospital admission during treatment, as well as the most frequent complication reported after treatment. And certainly in quality of life studies, we see that fatigue is a common side effect noted in people who've experienced infections, as I'm sure all of us have. So when we think about the immune system, I would say I often think of this most simplistic view where we think about the bone marrow, which is the factory that makes all the cells, and it makes red blood cells, white blood cells, and then platelets that would clot the blood. And of course, when you see your doctor, you would get a complete blood count, and you'd look at the breakdown of the white blood cells, and oftentimes we're very focused on, what is the neutrophil count, and does it look good enough to go ahead with the next round of treatment. But I always have to take a step back and remind myself that the immune system is far more complicated than just thinking about the blood cell counts alone. So I hope this isn't too in-depth, but I wanted to take you through two parts of the immune system that we think about. So we have the fast part of the immune system called innate immunity, and the slower part of the immune system that takes days to weeks to work called adaptive immunity. On the innate immunity side, we can think of three different categories that the immune system uses. So this seems a little simple, but the physical barrier is actually super important to our immunity. Thinking about the skin, we have three layers of skin, and even within the skin, we have these antimicrobial peptides that are secreted to try to kill off microbes before they get in. If we look at the GI tract, the reproductive organs, the lungs, they're all lined with these epithelial cells to block entry into the organ and also have mucosa that's meant to further add a layer of protection. And then we have these little hair cells called cilia in our lungs and our nose, and they're also meant to help transport out microbes. In terms of the chemical barrier, we can think of our stomachs, and the stomach acid that's there is there to help kill off microbes that might be consumed. And then there are these enzymes called lysozymes in our eyes and our saliva and our mucosa that are meant to break down microbes as well. There's other sort of various chemicals that you can find, like interferons or defensins, and they all have their own special roles at decreasing the rate of viral or bacterial or fungal replication and invasion into the system. And then finally, we have the fast-acting immune cells. So I think we know well about the neutrophils, but there are mast cells, macrophages, complement, natural killer cells. And all of these we can think of as the first line of defense against infection. So things about innate immunity, it's already there. It's not specific, and it's not super potent, but it is very fast, so it can act rapidly. It doesn't have a memory though, so if you get COVID one year and then you get COVID again the next year, it's not going to do a better job the next time. It's going to do the exact same job. Whereas on the other side of the immune system, we have the adaptive immunity, and the innate immune system communicates with the adaptive immune system through these antigen-presenting cells. So they kind of alert the T cells and the B cells that something's going on, and that's when the T cells and B cells start to do their work, where they become very specific and try to recognize exactly what's going on and create antibodies and very specific cells against the infection. So these are created in response to infection. They're very specific, very potent, but slow because it takes a while for these cells to kind of do their job and to differentiate. But the bonus is that these cells can have long-term memory, can live with you forever and protect you long-term from infections. So a couple of examples. So say you cut yourself and you get some swelling and redness around the cut. We could think of this as the innate immune system causing all this inflammation and protection in the area. The adaptive immune system, so say you get the COVID vaccine, depending on the type of vaccine, takes 1 to 4 weeks to develop memory, but you'll get T cell memory and antibodies, and that's going to save the time for you if you actually get the infection later. Now we don't need to wait weeks for the adaptive immune system to work. Those antibodies and T cells can work right away. When we think about the immune system, we also think about sex and gender differences. So it's actually true that women have less severe colds and less severe COVID and other infections compared to men, and it's thought to be related to the fact that we have more estrogen, which has an anti-inflammatory effect. Men have more testosterone, and this dampens the immune response. And we might think that that sounds bad, but actually, the immune system has this yin and yang where we don't want too much or too little. So the fact that men have more testosterone actually means they have less autoimmune diseases. And then there's other things. These are just a few examples, such as angiotensin 2, which is different between men and women and can cause inflammation and blood vessel constriction. Regulation of immune response is different on the X and Y chromosomes. And then we might hypothesize that men and women have different behaviors in terms of health behaviors and risk of contracting infection. And before we jump into lymphoma, I just wanted to highlight that that's not the only thing that affects our immune system. There's lots of research on all of these things and how it can affect immunity. So, for example, we know that getting older does result in decreased immunity. We know chronic medical conditions like cardiovascular disease, diabetes, COPD, obesity, and autoimmune disorders, just to name a few, can all affect the immune system. Eating a good diet is important to maintain healthy immunity. Exercise is important. We'll talk about this on the next slide. Health behaviors like smoking and alcohol use can also affect the immune system. And mental health and stress is super important as well. We know when people have more stress or depression or anxiety, that can also decrease immunity. And sleep is another important aspect. The reason I mention all of these factors is because I think we sometimes can't control the lymphoma, we can't control the need for treatment, but we can control some of these other things. So I think just thinking about ways that we can optimize our health outside of the lymphoma actually could strengthen the immune system in the long run. But I did want to highlight that I think, it's easy to get really caught up and think you have to be perfect and everything, but For me, I think moderation is still key, so I just wanted to share a couple of examples of that. So in terms of what can you do to boost your immunity, well, there's lots of vitamins that are needed to boost the immunity of all of these different organs, and this diagram kind of reveals the different vitamins that are used. But the challenge is too much of a good thing is also not so good. So for example, too much vitamin C can interact with chemotherapy and reduce its metabolism, or it could even cause kidney stones. Too much vitamin D could cause high calcium levels. And so I think in general, I'd say moderation is key. Similarly with exercise, if we look at this study, we can see that they had taken 160 women and asked them to either remain inactive or walk, and they tracked their upper respiratory tract or cold symptoms, and people who walked tended to get less cold symptoms. But again, too much of a good thing is not so good. So studies in athletes have shown that once they have a race or heavy exertion for a week or so after, their immune system actually decreases and they're at higher risk for infection, whereas moderate exercise appears to transiently improve the risk of infection. So we'll move on now to lymphoma. Um, so I think a lot of patients that I have kind of noticed that they've had a lot of infections in the years leading up to their diagnosis. And this is definitely something that's true, that's observed on the population level. So there's a study from Sweden looking at thousands of people who were diagnosed with lymphoma, right up until the peak of this curve where they were diagnosed. And up to 15 years before their diagnosis, there were higher rates of infection compared to the general population. And that really escalated in the 1 year prior to treatment, or prior to diagnosis, I should say. So I would say one hypothesis of why that's happening is we can think about the tumor microenvironment. So we know lymphoma cells develop over many, many years, and they create this environment around themselves where their goal is to hide from the immune system and prevent the immune system from killing off these cancerous cells. And in doing that, they end up doing things to also suppress the immune system around them, which then can have downstream effects on immunity in the rest of the body as well. What about lymphoma treatments? So I think we heard in the previous session a bunch of different types of treatment for lymphoma. So things could include chemotherapy, monoclonal antibodies, antibody drug conjugates, targeted therapy, immune checkpoint inhibitors, transplant, immune modulators, CAR T therapy, T-cell engagers. And for each of these treatments, I think if you asked your oncologist or if you tried to kind of pin down what is the way it's reducing your immunity, think we could all try to like pick one or two things that it's doing. So for example, chemo can cause mouth sores, can cause diarrhea and impact the mucosal barrier, and can definitely cause neutropenia. Or rituximab, for example, could cause B-cell depletion. But I think at the end of the day, because the immune system is so interrelated, probably the mechanisms of disruption from treatment are way more complex than we can easily explain or imagine. And so an example of that is, let's take R-CHOP chemotherapy or BR chemotherapy, where of course the number one thing we're looking at is the neutrophil levels and the other blood levels before each cycle. But thinking about it, this probably impacts all aspects of the immune system. So the mucositis or mouth sores you get can affect the physical barrier. Maybe you end up on prednisone maybe you end up on pantoprazole because of the prednisone to reduce stomach acid. That can reduce the chemical barrier. We know chemo kills fast-acting or rapidly dividing cells. And then the rituximab gets rid of the B cells, but chemo also kills off T and B cells. So probably multifaceted immune deficit that's caused by treatment. So then I guess for me, the next question was sort of, well, if lymphoma itself is causing increased risk of infection, if we get rid of the lymphoma long term, will we actually result in a better immune system? So can taking on the risks of treatment be worth it to end up with a better immune system down the road? And the short answer is I'd say we don't really know the answer to this yet. If we look at the pro side, if we look at various treatments, with a good example being ibrutinib in CLL or mantle cell lymphoma, It's been shown to improve features of the immune system. But on the con side, treatment unfortunately does decrease immunity, and this can last a lot longer than we expect. So this other study from Sweden looked at people with mantle cell lymphoma who had treatment and found that their risk of infection was increased for up to 8 years following their treatment. There was another study this year where people looked at leukemia, breast cancer, and aggressive lymphoma and found that cancer seems to leave some sort of immune scar that can persist for years after the treatment. So I'd say currently there's studies ongoing to answer this question, can treating lymphoma improve infection risk? And so one example is a study in Denmark called Prevent-ACAL, where they're looking at whether early treatment can specifically prevent infection in people with CLL. So now that we've talked a bit about the immune system, we'll move on to types of infections. So there's 4 different types of infections I would think about, including viruses, bacteria, fungi, and parasites. For viruses, the common ones I think about would be things like the chickenpox virus, which causes shingles, herpes virus, which causes cold sores, COVID, flu, RSV. Bacteria you may have heard of include Staph aureus, Strep pneumonia, E. coli. Fungi include things like Candida, Aspergillosis, Pneumocystis, and parasites could be things like malaria, Strongyloides, Giardia. So where do we get exposed to all of these bugs? I like this infographic because it reminds me that most bugs that we are exposed to are within ourselves. So we actually have more microbes in our body than actual cells. And so we have 100 trillion microbes in our body, 95% of which live in the GI tract. So just something important to keep in mind is some of the risk of infection just comes very naturally from what's in us or on us. Where else might we get exposed? Well, we could get exposed from insect bites, like mosquitoes can carry malaria or West Nile, animal feces, animal saliva, food, things like Listeria, Salmonella. So we've talked about humans already. In the air, we can get things like viruses or pneumonias. Water can carry things like Hep A infection, and then soil and plants can carry bacteria, but also different types of fungal infections. So then I guess the question is, we're all exposed to this stuff all the time. So how does that actually end up causing an infection? So we start with step 1, which is we're exposed, and then we are what's called colonized. So the bacteria or the microbes live within us. They live in our guts, in our lungs, in our nose, on our skin, and they learn to coexist with the immune system. And in many cases, they actually help us. So, for example, bacteria in the gut help us with our immunity and our digestion. However, unfortunately, at some point when your immunity goes down, whether it's stress or aging or having lymphoma or being on treatment, that's when these microbes can take hold and cause an infection. So I wanted to list a couple of examples of colonization. So step 2, moving into infection, which is step 4. So for example, E. coli is the most common bug found in our gut. But if you're on treatment, sometimes the bugs can escape into the blood and cause bacteremia or sepsis. In terms of viruses, many of us have had chickenpox, which actually lives in the nerve roots forever and at some point can get reactivated and become shingles. Similarly, 80% of people have had a cold sore, so the herpes virus then lives in the nerve roots in the face and the mouth and can reactivate and become a cold sore. In many parts of the world, people commonly develop Hep B infection, and that can live forever in the liver cells. And then when you're on treatment, it can come awake again and cause reactivation. With fungi, if you've been on certain types of treatment, you may have your oncologist putting you on PJP prophylaxis, and that's to prevent this fungus, which lives in about 25% of our lungs, come awake and cause a pneumonia. And Candida, for example, is in our lungs and our mouths. And an example could be if you get antibiotics, you end up with thrush in the mouth, and that's the Candida getting to become more active. So now that we've talked about the immune system and infections, what are some things that we can do? And so this is a list of things I came up with. It's definitely not an exhaustive list, but I hope to take you through these 6 things, which include vaccinations, testing and prevention, hand hygiene, masking, immunoglobulin replacement. And then number 6 is not really preventing infection, but I just wanted to highlight the importance of seeking prompt medical attention if you do have symptoms. So we'll start with vaccines. This study was really nice because it summarized that a lot of the vaccines we recommend do have data very specific to people with lymphoma, showing that they're helpful. And the vaccine that has the most data is actually the COVID vaccine. So definitely we would recommend people get 3 doses of the COVID vaccine as a minimum, plus 1 additional. That's the current Canadian guideline. And then if you've already had that, I would suggest getting a yearly booster. For the shingles vaccine, we know that there's data showing it actually decreases the risk of shingles in people with lymphoma by 64%. So it seems pretty worth it to get, and it's 2 doses given 2 to 6 months apart. Pneumonia can be prevented by this new vaccine that came out last year called PCV20, which replaced the 2 vaccines previously given. The flu can be prevented by the yearly influenza shot, and RSV is new, came out, I think, 1 or 2 years ago, and is also a single dose. A comment to make about live vaccines is they may be contraindicated based on your special situation, so always talk to your hematologist before you get a live vaccine. So, this talk is about prevention during treatment, so I guess the question is, what if I'm starting treatment? Well, I think the number one thing I would say is that any non-live vaccine is safe when you're on treatment. So whether you're starting it or already on it, I would say that it's considered safe. But obviously we want the vaccine to work. So the best time to vaccinate yourself is before you start any treatment. So if something's completely new to your body, so for example, when COVID first came out and we first had the vaccine, we wanted people to get the vaccine 4 weeks before they started treatment. But if you're getting a recall vaccine, which is something your body has seen before, like a booster shot, the flu shot, around 7 to 14 days is considered sufficient to get your vaccination. Of course, I think treatment takes precedence, so you want to talk about the timing, the urgency with your doctor. And then we also would recommend getting household contacts vaccinated. And the reason is because, if they're not getting infected, that's going to decrease your risk of infection. And then if they did get an infection, vaccination also decreases the amount of virus that's kind of secreted in their body. What about things like rituximab or binavituzumab, anti-CD20 therapy? I would say that although we know the antibody response is low in people who are on this treatment, there's very low harm, there's potential benefit to a small boost, and we also know vaccines can help the T cells as well, which aren't affected by rituximab. So I would suggest that it's still quite reasonable to get even if you're on these types of treatments. This is a study I like to mention because it's an Ontario study done by one of our fellows, where we were kind of looking at how is vaccination helping people with cancer. So we looked at thousands of people who'd had blood cancer during the pandemic, and this was specifically during the Omicron wave. And this graph is specifically for people who are on active treatment who'd had at least 2 shots. So at first look of this graph, we see that compared to people without cancer, people who are on treatment for blood cancer have a significantly higher risk of emergency visit, hospitalization, or even dying from COVID. But when we take a deeper look at the data, we did find that actually getting 3 doses compared to 2 improved outcomes. So it does show that incremental benefit of vaccination. And the risk is, of course, very high, but if we look at the absolute number, it was still less than 5% over 1 year. The risk of death was less than 1%. And this was also true in people who were on active rituximab-based therapy. So I think the message is, vaccination works, and it's always reasonable to consider getting to try to protect yourself. Category 2 would be testing before treatment. So this is all up to your hematologist. So what they would do is they look at the treatment you're getting, they look at you and your personal history, where you're from, where you've traveled to, and decide which of these which of these organisms they should test for. And the reason for testing for any of them is that all of them have an intervention available to help prevent infection or reactivation. What about medications that you could take to prevent infection? So a few examples include things like valacyclovir or acyclovir. I would consider this in a person getting treatment that's really affecting T cell health, or someone who gets cold sores or genital ulcers during their treatment, or anyone with a history of shingles. Septra, atovaquone, or pentamidine can be considered for PJP prophylaxis in treatments affecting T cell health. We use Grostafil or Neupogen as white blood cell boosters in anyone that is judged to have a higher than 20% risk of febrile neutropenia during treatment. And then things like antibiotics or antifungals would really only be used in chemotherapy type treatments that are going to cause a very long period of low neutrophil levels. So number 3, hand hygiene. So this was a really interesting study done in Michigan where they kind of went and just observed people in public restrooms and looked at 3,700 people and found that only about 1/3 of men and 2/3 of women washed their hands at all. And only 5% did it properly, which they defined as, getting soap, doing 30 seconds of rubbing and washing. Why is hand hygiene important? Well, there's a ton of studies on hand hygiene, and they all have varying quality. So the estimate of reduction is hard to make, but we could say there's up to a 50% reduction in these studies preventing respiratory and GI illness. Why is that? Well, if you look at this petri dish, an unwashed hand touching it grows a bunch of bacteria, a rinsed hand grows less, and a fully washed hand grows even less. And if we think about that fully washed hand, that's what's rubbing our eyes, rubbing our nose or eating food and potentially exposing us to these microbes that are out there. What about masking? So I really like this modeling study that was done in Minnesota. And they basically were trying to look at how masks worked in the setting of COVID-19, specifically to prevent COVID. And so if we think about COVID, it has an aerosol type of spread, which is the most contagious type of spread akin to tuberculosis. It can hang in the air for ages after someone leaves the room, for example. So they kind of modeled if you wore no mask, a cloth mask, a surgical mask, a non-fitted N95, or a fit-tested N95 that a healthcare provider might wear. And the person who had COVID was doing the same thing. How long until you got infected? And so I think the two at the each end of the spectrum would be if no one's wearing a mask, within about 15 minutes, you could contract COVID. And this is sort of modeled on an average sort of healthy immune system. On the other hand, if both people are wearing really well-fitted N95s, you can last 25 hours in that room. And I think this reminds me why healthcare providers who have to wear N95s when we're seeing people with COVID, we don't tend to get infection even though we're caring for people with these illnesses. I think the most relevant one for me was like the surgical mask with someone who has COVID who's not wearing a mask, because that seems like a common situation in life, like if you're out at the grocery store or something. And again, this is just a modeling study, but it seems to support that you can have a transient period of interaction with people if you're wearing a surgical mask, and still try to keep yourself safe. The limitations of this, it is a model, and this was done in the setting of COVID, so this depends on the virus, the transmissibility of the virus, how much virus the person has. And I think the final piece that I wanted to point out is that lots of studies have looked at outdoor transmission, and it really depends on like pollution levels and wind and temperature. But in general, we can say that the risk of transmission is really low outdoors and at least 18 times less than indoors. So for me personally, I don't wear a mask when I'm outside, but that all comes down to personal preference as well. Topic number 5 would be immunoglobulin replacement. So this is a blood product that's made from thousands of healthy donors, purified, and then put into this glass bottle. It is given to people who have low antibodies who meet certain criteria. The criteria are a low IgG level, and one infection requiring IV antibiotics, or two or more infections requiring oral antibiotics, especially if it's in that head and neck area, sinus and lung infections. Why do we do this? So this leads to the challenges with using IVIG or SCIG. All the data supporting it is from these really old trials from the 80s and 90s, when obviously treatments were way different than they are now. It's still a blood product, so there are risks to using a blood product. There's time toxicity and financial toxicity to you as a patient, driving to the hospital, spending money on parking or taking the bus, and also toxicity to the healthcare system, of course, as we live in a publicly funded healthcare system. And the final challenge is that when we look at immunoglobulins and how they work, the ones that we really want are the IgAs that line the mouth and the throat and the lungs and the GI tract. Um, but we can't replace those. We can only replace the IgGs, which tend to be found more in the blood. And thinking about how complicated the immune system is from the slide earlier, it really probably doesn't fix the whole problem. Um, Recently, a group in Australia has called attention to the fact that we don't really have good data to support the use of immunoglobulins versus other measures. And so this trial called the Rational Trial is now opening in Canada as well. So it may be coming to a hospital near you. And I would definitely encourage you to participate because I think this will give us really valuable information on when should we start antibiotics, when should we start IVIG? Do we need IVIG or can we get away with just antibiotics, which is the standard treatment in other countries such as the UK or Australia? When can we stop immunoglobulins and what dose should we use? So they're looking at lots of different outcomes to try to help us get to the bottom of this. And category number 6 would be reminding you to seek prompt medical attention with any symptoms of infection. So fever while you're on chemotherapy is considered a medical emergency. Your oncology team may provide you a fever card, but if not, when you go to the triage desk, you just need to let them know that you're on chemo and you have a high fever. The standard recommendation is that from the time you arrive to the time you get antibiotics should be less than 1 hour. So you can kind of use this information to advocate for yourself, and sometimes these fever cards also help with that. If you're on other types of treatment like chemo, or if you're on chemo and you have infection symptoms but no fever, you still need a same-day assessment. So whether it's calling your oncology team, going to your family doctor, going to an urgent care clinic, the emergency room, or if you feel unwell, calling 911, infections can still be quite significant even if you're not on chemotherapy. The positive news is, immunity will improve with time after treatment. And so, for example, this is a schematic showing that 6 to 12 months after finishing rituximab or anti-CD20 therapies, the B cells will recover and they will continue to recover over the next couple of years. Similarly, after a type of chemotherapy called bendamustine, we can see that, yes, the T cells do recover with time, so time will help. The final point I wanted to make is about risk tolerance. So this is kind of the concept of whether you are someone who has low risk tolerance or high risk tolerance. So someone who has low risk tolerance might place a very high value on decreasing their personal risk of transmissible infectious diseases, whereas someone with high risk tolerance might place high value on maintaining their social contact or having important gatherings. And of course, your risk tolerance may vary depending on the treatment you're on, or what season it is, or what the event is. So to conclude, I guess we could say the immune system is very complex, and lymphoma and its treatments can cause immune suppression in numerous ways that are very hard to pin down very specifically. Not all infections come from other people, and many infections come from bugs that live on us or in us. There are actionable steps you can take to minimize your risk of infection during treatment. Immunity will get better with time after treatment. And at the end of the day, infection prevention is unique and personal, and it has to be customized to your own values and preferences. So I hope that was helpful, and I'm happy to take any questions.
Thank you, Abby, for that very informative presentation and walking us through those 6 methods of preventing infection. There were some great comments. Somebody said that the risk tolerance slide is very important, and thank you for including that. So with that said, we'll get directly straight into the questions for the sake of time. So other than IgIV, are there other injectable products that patients may use to boost their immunity?
Oh, yes. So I think he may have been referring to a subcutaneous immunoglobulin. So there are weekly and monthly products that are available that you can do at home.
Yeah. And what if my treatments are finished? Should I be getting the COVID vaccine? I've had 8 COVID vaccines already over the course of time. I finished my treatments in 2018.
Yeah, this is a good question, and it's likely that your immune system has probably recovered quite a lot. I I think at least now we think that the flu and COVID shots every year are probably getting more targeted towards the current strains. So I still think it's valuable to get a yearly booster of both of those things, and I definitely do that even myself.
Okay, and there's a few questions on chickenpox. So can being vaccinated for chickenpox also make shingles possible? And your thoughts on the shingles vaccines for a 34-year-old?
Yeah, very good question. So no, if you've been vaccinated for chickenpox but you've never had it, technically speaking, you should not be able to have shingles later on unless somehow you got the infection, you were never aware of it. In terms of the shingles vaccine for 34-year-old, I think this is always a personal decision between you and your family doctor and your hematologist. So, for example, in Ontario, the shingles vaccine is around $300 and it's only covered for people aged 65 to 70, unless you have private insurance. So sometimes cost weighs in. But I'd say if you're starting treatment, and your immune system is considered low from your lymphoma based on discussion with your hematologist, I think it's reasonable to get at any age.
Okay. And if someone needs multiple vaccines, such as shingles #2, COVID, flu vaccine, pneumonia vaccine, this fall, what is the best time period to wait between administration?
Yeah, I think probably our family doctors know this better than anyone, but I always think of like for babies, we take them in, we give them like 4 shots at once. So that always reminds me that it is safe to get multiple vaccines at the same time. But just because it's safe, it might not be very comfortable because you might not want like an extremely sore arm. So I would say you could use your discretion in that circumstance and wait whatever period of time feels comfortable. And I would just prioritize, things that are seasonal, such as COVID and flu, before others.
Okay, and the next question is very situational. So this patient lives on a ranch with domestic animals. Anything different that I should do when I start BTK inhibitors upon relapse?
Yeah, very good question. So yes, I think, there's again, this comes down to the risk tolerance slide. So, the most risk averse person would say, I'm not going to do anything with the animals, I won't do any of the cleaning, etc. Whereas maybe on the other end of the spectrum, using gloves and making sure you're not touching anything with your bare hands, lots of hand washing, maybe wearing a mask, would be ways to try to mitigate infection.
Okay. And when should an individual be revaccinated for some childhood vaccines like measles, etc.?
Yeah, that's a really good question. I think measles is something I should have mentioned because it's a really relevant topic right now. I can only speak to the way our hospitals, infectious diseases, doctors provide recommendations. But in general, I would say before you get any live vaccine, you should always talk to your own doctor about whether it's considered safe, considering your personal history. So whether that's yellow fever, measles, or whatever else. Um, and our current recommendations are that if you get your measles serology checked and you have the immunity that's still there from childhood, you don't need to get revaccinated. If you don't have the immunity, then that goes down to that personal decision with your oncologist. That may involve checking your T cell levels. Regardless of whether you're positive for immunity or negative, the way that we do it at our hospital is if you're ever told that you're exposed by public health, you don't need to remember anything other than to call us because we give antibody prevention treatment to anyone with hematologic malignancy because we think we don't necessarily want to trust the blood test results. We want to just try and prevent the infection.
Okay, and the next question, should I pause my subcutaneous immunoglobulin infusions before getting my next Shingrix vaccine?
That's a great question. I don't think so. I think that, yes, you're right. The subcutaneous immunoglobulin would make it look, if we checked your blood, it would look like you had antibodies against shingles, even if they're not yours, they're someone else's. But it shouldn't affect your body's ability to respond to the vaccine itself.
And there's a patient who mentioned that they've been told that for folks who are immunocompromised, a recommendation is every 6 months, not yearly, for the COVID vaccine. And this has been advised by both infectious disease and Princess Margaret. Is this the case?
Yeah, I was looking at the current Toronto guidance, and I think that it always tends to change. So I think the best thing to do would be to follow whatever is the most current NACI guidelines.
And the next patient was treated the second time for marginal B cell lymphoma. And how do you distinguish between a bacterial infection versus a virus, and how quickly do you take antibiotics?
Yeah, that's a good question. I think, of course, bacterial versus viral infections can manifest in so many different ways, like through our entire body. So I think the best thing is really to get checked out by a healthcare provider in that circumstance.
Okay. And it's very rare to get hypogamma with the type of cancer that this individual has. But is the new trial that you mentioned open for individuals like them, or what do they do with people like me in other countries?
Um, Yeah, good question. So if you don't have hypogammaglobulinemia, meaning your IgG level is totally normal, we don't then tend to think about immunoglobulin replacement in that circumstance. So the trial wouldn't necessarily apply to you. In other countries, what they do instead of immunoglobulins is to give antibiotic prophylaxis. So for example, daily Septra or daily doxycycline. That's not really the culture in Canada, but in other, Commonwealth countries like the UK or Australia, that's the first line of treatment before the blood bank will even approve using immunoglobulin.
Okay. And do boil water advisories affect patients who have gone through treatment? And are there any additional medication vaccines they should take?
Oh, that's a great question. I feel like I don't know enough about water safety to answer that well enough. It's a very good question that I'll take back to our group.
And the next question, this patient doesn't have a spleen, so should they avoid all live vaccines?
Um, So I'd say if you don't have a spleen, there's definitely vaccines that we want to make sure you're up to date with, and any fevers, you would be someone that we would recommend to go get checked out in the emerge right away. But the live vaccines comes down to usually T cell immunity. And so I think I would think of it a little bit differently than having or not having a spleen.
Okay. And this is a question that we get often from patients. So the individual said, I often experience aches and fatigue. How can I tell if I'm having a more severe reaction to a vaccine, and when should I contact my physician?
Yeah, that's a great question. I think you have to trust your body, right? I think the only thing I could say is you know your body. So if something doesn't feel right, I'd always rather someone call and find out if everything's okay than to maybe not know and to worry about a side effect that could happen.
Perfect. And I think that was our last question for the day. Thank you, Abby, for taking the time to answer all these questions and for that very informative presentation, lots of takeaways. And with that said, thank you everyone for joining the session as well. And I'd like to direct your attention to attend the next session titled Understanding Targeted Therapies for Lymphoma and CLL. It will be starting in 5 minutes or so. So this is your chance to take a break, perhaps stretch, perhaps explore the rest of our platform. We have lots of resources available. So I hope to see, with that said, I hope to see you in the next session. Thank you, everyone, and see you there.